Students, boost your skills with our new Paediatric First Aid podcast.
Essential listening before your practical course.
Hello, everyone, and a very warm welcome to this deep dive. This is your essential audio companion to the First Aid Garage Pediatric First Aid Manual.
It is indeed. I am Ernie.
And I'm Andrea. We're both thrilled you've chosen to join us today.
And, like you, I've spent years working as a paramedic here in the UK. We've seen, countless scenarios firsthand.
Oh, absolutely. Everything from simple playground bumps to those really critical, life-threatening incidents. We absolutely know the pressure you face.
Yeah. And you are here today as part of your training with, the legend himself, Paul Kenny, and the First Aid Garage team.
Exactly. We might have some road experience, but Paul has over 40 years under his belt. 40 years dealing with pediatric emergencies all across the UK.
He really is the standard.
He is. And this deep dive, it's designed to make his manual come alive, really, to get you ready for your hands-on session.
Our mission today is, it's crystal clear. We want to walk you through the most critical sections of that PFA manual.
And we're going beyond just, reading the protocols.
Exactly. We're going to discuss the signs, the symptoms, and the exact specific UK steps you need to take when you're faced with a child in distress.
We're targeting this specifically for you.
For the nursery staff and the primary school teachers, you're the ones looking after that 0 to 11 age range.
So let's just quickly define our terms right at the start, shall we?
Good idea.
When we talk pediatrics, we're really talking about two main groups you look after. First, we have infants.
So that's any child under the age of 1 year.
And then we have children.
And that's anyone from 1 year up to 18, though, your immediate focus is mostly going to be on that primary school cohort.
Spot on. So before we even touch on a specific injury, we have to internalize the three core aims of pediatric first aid.
Yes. Every single decision you make in an emergency, it really should align with these goals.
The first one is, it's the most obvious one. It's to preserve life.
Right. And that means intervening with immediate, effective first aid, whether that's CPR, controlling a bad bleed, or managing an airway.
It's all about saving that child's life.
The second aim is to prevent the condition from worsening.
This is all about making a rapid assessment, isn't it? Recognizing what's wrong and then applying the correct protocol to stabilize them.
It is. For instance, putting a child with a suspected fracture into the recovery position might actually make the fracture worse.
So stabilizing them in the position you find them in, that prevents further injury?
Exactly. And the third goal, which I think is often overlooked, is to promote recovery.
It's not just about calling 999, is it?
Not at all. It's about providing that ongoing high-quality care, monitoring their vital signs, keeping them safe, and giving that essential emotional support until, qualified medical help arrives.
If you keep those three aims in your mind, your decision-making framework is already solid.
Absolutely.
Okay, let's unpack the groundwork. Before an incident even happens, you need what Paul Kenny calls the First Aid Garage checklist.
Getting your policies and your gear ready.
Right, because if you have to stop in a real emergency just to find a pair of gloves, you've already lost critical time.
You really have. It all starts with safety and specifically infection control. We, as first aiders, as carers, have a fundamental responsibility here.
We have to make sure we don't transmit infections to the child.
Or pick up an infection from them. It's just basic professional diligence, isn't it? Meticulous personal hygiene, making sure any cuts or sores you have are covered.
And thoroughly washing your hands with soap and water after you take your gloves off.
Even if you think the gloves worked perfectly, every single time.
And that takes us directly to PPE, personal protective equipment.
Your essential barrier.
The manual insists on three specific pieces of equipment being ready to go. First up, nitrile powder-free gloves.
Yeah, nitrile is definitely preferred over latex because of how common latex allergies are. And they must be powder-free. They have your #1 barrier against blood and other bodily fluids.
Second, you need pediatric pocket masks.
These are absolutely essential barrier devices if you need to perform rescue breaths.
Oh.
In today's environment, it's crucial for cutting the risk of transferring airborne diseases or, vomit or blood.
It just makes the whole procedure safer for everyone.
For both you and the child.
And the third item, which I think can often be forgotten in a rush, is eye protection.
Oh, this is non-negotiable. Especially in severe trauma or when you're dealing with a vomiting child. It just eliminates that risk of fluids splashing into your eyes. You have to have these barriers in place before you start.
Beyond the immediate incident, having solid administrative policies is just Well, it's paramount in a school or a nursery setting.
Definitely. If you're ever required to administer medication, you must have a written, unambiguous policy that outlines the procedure.
And more importantly,
You need explicit written parental or guardian permission to administer any medicine to a child in your care.
and storage is key too. Medicines have to be stored strictly according to the manufacturer's instructions.
Which is usually cool and dark. And they need to be clearly labeled with the child's name.
And, this is critical, they must be kept in their original containers. Why the original container?
Because that container carries vital information, doesn't it? The dosage, the expiry date, specific warning labels.
So if you transfer medication into an unmarked box,
You remove that entire layer of safety and accountability. It's a legal thing and a clinical necessity.
okay, so once the incident is managed, the paperwork starts. And incident reporting in the UK is governed by a whole range of statutory bodies.
Yeah, it goes way beyond just the school's internal accident book.
So if you're dealing with a serious injury, an accident, or, God forbid, a death, your setting is likely required to inform several agencies.
We're talking about the HSE, the Health and Safety Executive,
Mandatory reporting under RIDOR.
the reporting of injuries, diseases, and dangerous occurrences, regulations, and potentially Ofsted if you're a regulated childcare provider.
And on top of that, any suspected non-accidental trauma or child protection issues must be reported to the local child protection agency.
It sounds like a lot of red tape, but you have to view it as a system of learning and accountability.
Right. Your record needs to be clear, concise. Date, time, location, the child's details.
Exactly what happened, comprehensive details of the first aid provided and what actions were taken next.
Including the time parents were contacted. This data helps all of us identify trends and, hopefully, prevent future incidents.
So when you first arrive at an incident, you need a mental checklist, something to stop you from just rushing in blindly. We use the Scene Survey acronym CLAP.
C is for control the situation.
Stop. Take that one crucial deep breath.
Assess the resources you have, who you need to delegate tasks to.
Calling 999, fetching the AED, contacting parents.
You have to take charge and project calm, even if you don't feel it.
Then L is for look for potential hazards. This is your dynamic risk assessment. Is there spilled water? Broken glass?
Electrical wires, remember, your safety always comes first. Then the child's, then others.
You can't help them if you become a casualty yourself.
Then A is for a victim. Assess the situation.
Gather history from the child, from bystanders, from other staff. What were the signs and symptoms before you got there? Did they fall? Did they suddenly become ill?
That history is vital for the ambulance crew later on.
And finally, P is for protect and prioritize.
Put on your PPE, especially those gloves. Then you prioritize treatment in a logical order.
Paul teaches the 4 priorities. First, breathing or airway and circulation. Second, major bleeding.
Third, bones and burns.
And finally, other conditions. So if a child is bleeding heavily and has a suspected fracture, you always deal with the life-threatening bleed first.
That prioritization is based on immediate threat to life. Now, before you even physically touch the child, casualty communication is so important.
It really is. When a child is sick or injured, they are often just overwhelmed by fear, by pain, by the commotion of adults rushing around.
So your body language must be open, your tone calm, and your voice measured.
If you can, use their name. Let them keep a familiar object, a security blanket, a favorite toy, just to ground them.
And it's vital to be honest but reassuring. Continuously explain what you are doing and, crucially, why you are doing it.
I'm putting a plaster on now because it stops the germs from getting in and makes it feel better.
Exactly. Use slow, clear language. And avoid shouting, even if the scene is noisy. Involve them where you can.
Yeah, asking them to hold their arms still. It gives them back a little bit of control, doesn't it?
It does. So once the scene is safe and communication is established, we move immediately into the primary survey. The systematic approach we use for immediate life threats. DRABCD.
D is danger. A quick recheck. Is the scene still safe? Have any new hazards appeared?
R is response. Check their level of consciousness.
For an infant, you talk softly and stimulate gently. Maybe a light tap on the foot.
For an older child, you talk to them, gently stimulate them, and you loudly ask, "Are you all right?"
If they respond, brilliant. You keep them in the position you found them, check for further injuries in what we call the secondary survey, and just keep reassuring them until help arrives.
But if there is no response, we immediately move to A for airways.
Right. You place a child onto their back, and you open the airway using the head tilt-chin lift method. One hand on the forehead, gently tilting the head back, while lifting the chin with your fingertips.
Now, this is where the nursery staff listening need to pay maximum attention. Airway management is critically different depending on age.
It is. For an infant that's under 1 year, the head must be kept in a neutral position.
Why is that so important?
Well, the infant's neck is far more pliable, and if you overextend it, you can actually compress their own windpipe. You can accidentally close the very airway you're trying to open.
So keep the head straight. For an older child, the gentle head tilt is fine.
The visual cue we teach is the sniffing position. Imagine they're trying to sniff a flower. Their earlobe is in line with the shoulder, their nose is pointing slightly up, but their head isn't tilted way, way back.
Which is why the hands-on practice later is just non-negotiable.
Absolutely. Moving on, B is for breathing. After you've opened the airway, we look, listen, and feel for normal breathing for no more than 10 seconds.
You look for chest movement, you listen for air sounds, and you feel for their breath on your cheek.
And we must talk about agonal gasps.
Yes. In the initial stages of cardiac arrest, a person, adult, or child might take these slow, noisy, infrequent, gasping breaths.
They are reflexes. They are not normal breathing.
Yeah.
If you are in any doubt at all that the breathing is normal, you must treat them as if they are not breathing normally.
And prepare to start CPR immediately. Paul always says, doubt means compress.
Spot on. If they're unresponsive and not breathing normally, we jump immediately to C for call 999 circulation.
Call for an ambulance straight away. Ideally use a speakerphone so you can follow instructions, and send someone immediately to get an AED.
And finally, D is defibrillation. If an AED, an automated external defibrillator, arrives, you switch it on and you just follow the spoken prompts. It's used with CPR, not instead of it.
That DRA-BCD step brings us to a tough reality, which Paul always calls out. What if you are completely on your own?
Right. You're a single nursery worker, alone in the room with an unresponsive infant.
This is where Paul's practical pearl on the on-your-own rule becomes absolutely life-saving.
It does. If you are alone, you must prioritize getting oxygen into them first. You have to give 5 initial rescue breaths, followed by 1 minute of effective CPR before you go to call 999.
Wait, why the emphasis on treatment before the call? We usually tell people to call 999 immediately.
Because in children, cardiac arrest is almost always secondary to a respiratory issue. They stop breathing first, then their heart stops.
So if you can get oxygen into them straight away,
you significantly increase the chance of success. After that minute of CPR, you physically take the infant or child with you to the phone to get help, ideally using speakerphone while you carry on with the treatment.
Okay, but what if, in that 10-second check, you find the child is unresponsive, but they are breathing normally and effectively?
That is the perfect time for the recovery position, as long as there are no injuries that would prevent movement, like a suspected spinal injury.
And the recovery position serves 3 vital purposes, doesn't it?
It does. It ensures the airway is easily accessible and open.
It enables the free drainage of fluid from the mouth, so it stops vomit or blood from being inhaled.
And it assists with natural, effective breathing.
Again, the positioning is slightly different for infants and children.
For the infant, under 1 year, you hold them securely, facing you, with their head tilted slightly down. This position lets gravity drain fluids, and it lets you continuously monitor their breathing by looking right at their face and chest.
And for the older child, we need a stable mechanical position.
Yeah, you kneel beside them, make sure their airway is clear. You place the arm nearest to you out straight at a right angle to their body. Then you bring the other arm across their chest and hold the back of that hand onto their cheek.
Then you use your free hand to grab the clothing around the knee furthest from you and pull that leg up, keeping the foot flat on the ground.
And keeping their hand on their cheek to control the head, you pull their raised knee towards you so they smoothly turn onto their side.
And the final crucial step for stability is adjusting that upper leg so the knee and lower leg are at right angles to the hip.
That forms a wide, stable base. It ensures they won't roll backward or forward. And the hand under the cheek maintains that gentle tilt to keep the airway open.
And this is a monitoring position, not a set and forget position.
No. And Paul's practical pearl here is vital for those long waits for the ambulance. If they're delayed, say longer than 30 minutes, you should periodically turn the child onto their opposite side if injuries allow it.
To prevent pressure injuries from developing.
Exactly. But you must continually monitor their breathing and responsiveness the entire time you wait.
Okay, now we move into the actual interventions, the drills that save lives. starting with cardiopulmonary resuscitation, CPR.
Combining effective chest compressions with rescue breaths to manually pump blood and oxygen through the body.
As we touched on earlier, the pediatric protocol is fundamentally different from the adult one.
Yeah, and that's because the cause is usually different. We start with that priority we identified. 5 initial rescue breaths first. Because typically the child's heart has stopped due to a lack of oxygen.
Respiratory arrest, not a primary heart failure.
Spot on. So getting those first breaths in is paramount.
After those first 5 breaths, you start the cycles.
The ratio is the familiar 30 compressions followed by 2 effective rescue breaths. It's the same ratio we use for single rescuer adult CPR.
And the rhythm needs to be fast.
100 to 120 compressions per minute. If you need a cue, think of the rhythm of staying alive. That beat is perfect.
And the depth is equally specific. We have to compress the chest by at least 1/3 of its depth to be effective.
We're trying to manually pump the blood from the heart to the brain. To give you practical numbers, for an infant, so under 1 year, that depth is approximately 4 centimeters. And you use the tips of 2 fingers for this.
And for an older child?
That compression depth increases to about 5 centimeters. You can use 1 hand or 2, depending on the child's size, but that core measurement, 1/3 depth, must be achieved.
That's a good distinction. So for a primary age child, it's roughly squashing a tennis ball, but for a tiny infant, it's just a firm press on the lower half of the breastbone.
That's a good way to think about it. And when you're delivering those rescue breaths, remember the 2 attempts rule.
Right. Don't make more than 2 attempts to get effective breaths before you go straight back to compressions.
Don't waste vital seconds trying to reposition the head perfectly. If the first 2 attempts fail, get back on that chest.
And when the AED arrives, you integrate it seamlessly.
Place the AED towards the child's head, switch it on, and just listen to the voice prompts.
What about the pads?
Pediatric pads should be used for children aged 1 to 8 years. They deliver a lower, safer electrical shock. If the child is 8 or over, standard adult pads are fine.
But the manual also gives us a weight caveat, which is really important for some of the bigger primary school children.
It is. If a child is already over 55 pounds, which is about 25 kilograms or 4 stone, it's recommended you use the standard adult pads, even if they're not quite 8 years old yet.
And here is a crucial Paul's practical pearl on pad choice.
Yeah, this one's so important. If you are dealing with a smaller child, say a 4-year-old, and there are no pediatric pads available, do not hesitate. Use the adult pads anyway.
Using something is always better than using nothing at all.
Always. The AED will still provide a chance of survival that you wouldn't have otherwise.
Okay, let's talk about choking. This is arguably the most terrifying, sudden emergency you might face.
And getting the recognition right. Mild versus severe is the single most important first step.
So mild obstruction means air is still getting through.
The signs are forceful coughing, the child might be speaking or crying, their face might be red, and they'll show general distress.
And if they are coughing effectively,
you just assess and encourage them to cough. You don't intervene physically at this point. Coughing is the most effective way for them to clear it themselves.
But severe obstruction means life is immediately threatened.
Yes. The child will grasp at their throat, they'll be unable to breathe, speak, or cry, and their color will rapidly turn blue or gray.
Cyanosis. That blue or gray tinge is the ultimate red flag.
For a conscious, choking child over 1 year with a severe obstruction, if encouraging them to cough has failed, you move to physical intervention. You give up to 5 sharp back blows between the shoulder blades.
And you have to support their chest and lean them forward.
So the gravity helps dislodge the object.
And there's a really useful Paul's practical pearl for the smaller primary children here.
Yes, if it helps you get leverage and deliver those back blows effectively, lay the child across your knee or your lap. It gives you a really solid base to work from.
And if the back blows fail,
then you proceed to give up to 5 abdominal thrusts, the Heimlich maneuver. Stand behind the child, wrap your arms around their middle, form a fist just above the navel, and pull sharply inwards and upwards.
There's a vital warning here, though. A child who has received abdominal thrusts should always be taken for urgent medical follow-up, even if they seem fine. Why is that?
Because abdominal thrusts are forceful. They can cause significant internal trauma damage to the spleen, the liver, or ribs. It's a life-saving measure, but it carries a risk, and that risk needs to be properly assessed by a doctor afterwards.
Now, the protocol for a conscious choking infant under 1 is completely different.
It is. First, you look in the infant's mouth, but you only remove objects that are visible and easily accessible.
Never ever perform a blind finger sweep.
No, you risk pushing the object further down and lodging it securely in the airway.
So what do?
You support the infant in a head downwards position, usually cradled along your forearm or across your thigh, and you give up to 5 sharp back blows, making sure the head is lower than the chest.
And if that fails?
You immediately turn the infant over, still making sure the head is below the chest. Then you give up to 5 chest thrusts, using the tips of 2 fingers on the lower sternum.
So these are similar to CPR compressions, but sharper.
Exactly. They're delivered as a sharper, distinct jab, designed to create a pressure wave to dislodge the object.
And finally, what if either the infant or the child becomes unconscious while you're treating them for choking?
Then the protocol shifts entirely to CPR. You open the airway, look for the object again, and if you can see it and get it, remove it. If not, you give those 5 initial rescue breaths, and then you immediately start CPR.
30 compressions to 2 breaths.
It's the last line of defense.
Okay. Let's move on to trauma and bleeding. We have to stress a core physiological fact here. Size matters immensely with children.
It does. Children have significantly less blood circulating than adults. I mean, a typical 70-kilogram adult has about 5 liters of blood. A small primary school child might have 1.5 to 2 liters.
That difference is massive. It means a child can lose a critical volume of blood far, far faster than an adult.
Yeah, the manual notes the body struggles to operate if 1/3 of its blood has been lost. Blood pressure will plummet quickly. Losing 500 milliliters of blood for a primary school child is a massive emergency.
For an adult, it's a blood donation.
Exactly. We categorize external bleeding into 3 types. Arterial bleeding is the most life-threatening. The blood is bright red, and it pumps rhythmically from the wound.
Venous bleeding is also life-threatening. The blood is darker red and will gush or flow steadily.
And then you have capillary bleeding, which is typically a slow ooze from grazes and cuts. Usually not life-threatening unless the child has an underlying condition like hemophilia.
So for major bleed management, you start by putting on your disposable gloves.
Then sit or lay the child down immediately on a firm base.
Yeah.
This position is crucial because it helps to manage or prevent shock.
The first, most effective intervention is applying direct pressure onto the wound with a sterile dressing.
Use the flat of your hand to maintain firm, continuous pressure.
And if the blood soaks completely through that first dressing,
You apply a second dressing directly over the top of the first one, and you keep up the pressure. Don't lift the first dressing. You might disturb any clot that's forming.
here's the critical distinction in protocol. If blood then seeps through that second dressing,
You have to stop. You must remove both dressings and start again. This means the pressure wasn't correctly applied, or the seal wasn't good enough.
so continuing to pile dressings on top is ineffective.
Completely. If the underlying pressure isn't resolving the bleed, you have to reassess, clean up, and apply new, firm pressure with fresh dressings. And call 999.
What about embedded objects, a piece of glass or sharp metal?
You have to resist that instinct to pull it out.
Yeah.
It might actually be plugging the source of the bleed.
So instead you apply firm pressure to either side of the object.
Build up bulky dressings around it to support it, secure them firmly, and immediately call 999.
Major blood loss leads rapidly to hypovolemic shock.
And recognizing this quickly is essential. You're looking for pale, cool, and clammy skin.
Because blood is diverting to the core organs.
Exactly. Also, a rapid pulse and rapid, shallow breathing, general weakness and dizziness, and often agitation or anxiety because the brain isn't getting enough oxygen.
Shock treatment begins with an immediate 999 call.
Treat the initial cause, like that major bleed. The position is key. Lay them down, and if there are no head or spinal injuries suspected, raise their legs slightly above the chest level.
This encourages blood flow back to the vital organs.
Loosen any tight clothing around the neck or waist, keep them warm with a blanket or a jacket, and this is a critical rule. Do not give them any fluids.
Nothing by mouth.
Nothing. If they're in shock, their circulation is compromised, and giving them fluids can complicate treatment if they need surgery later on. And you must constantly monitor their airway and breathing while you wait.
Most of what you'll deal with are minor injuries, but even these need proper care. For minor cuts and grazes, put on your gloves.
Check for small embedded bits of dirt or grit. Clean the area with a sterile wipe or fresh running water.
Apply direct pressure to stop any ooze, and then apply a dry, sterile dressing or a plaster.
Splinters are very common. If they are partially embedded, put on your gloves, clean the area around it, use sterile tweezers, and draw the splinter out along the path of entry.
Never across the grain.
No. Then clean the area again and just monitor for signs of infection over the next few days.
And if the splinter is fully embedded?
We teach the drawing technique. You cover the splinter site with a plaster or a bit of tape, and you leave it overnight. The moisture and mild irritation under the dressing can sometimes draw the splinter out or at least bring it closer to the surface.
But if the splinter is large, deep, or particularly if it's under a nail?
Don't attempt removal. You need to seek qualified medical attention for sterile removal.
Now for another of Paul's practical pearls. The dreaded nosebleed.
These look far worse than they usually are, don't they? The amount of blood can be really alarming.
The treatment is specific and must be followed. Sit the child down and, crucially, ask them to lean forward.
This stops blood running down the back of the throat, which can cause nausea and coughing.
Ask the child to breathe through their mouth and pinch the soft part of their nose, just below the bony bridge.
And you must maintain this continuous pressure for a full 10 minutes. Use a clock, not a guess.
When you release the pressure slowly, if it's still bleeding, you repeat the process for another 10 minutes.
And if, after 30 minutes of continuous pressure, the nose is still bleeding, you seek medical help immediately.
And remember to tell the child not to pick the crust that forms. That's the clot keeping the wound sealed.
Spot on.
Right, let's move on to sudden illnesses and medical conditions.
Okay, so when a child has fallen heavily, especially from a height, or taken a direct impact, we have to consider bone injury.
We classify fractures by how they look. Closed, where the bone hasn't broken the skin.
Open, where the bone has pierced the skin. Or in children, you often get a green stick fracture, which is an incomplete break where the pliable young bone just bends and partially breaks.
Fracture recognition involves severe pain, tenderness, noticeable bruising, swelling, a visible deformity.
The inability to move the limb, and sometimes something called crepitus, a grating or crunching sound or feeling when the injured part is moved.
Fracture and dislocation treatment is, thankfully, identical for first aid. Put on gloves, treat any major bleeding first.
And the absolute golden rule taught by Paul: immobilize the limb in the position found.
Do not attempt to straighten it.
No, you risk further damage to surrounding nerves and blood vessels. Use slings, padding, whatever you have to make the child comfortable and keep the limb still.
Monitor them closely for signs of shock and immediately call 999.
And you treat dislocations where a joint is displaced using the exact same protocol.
For less severe soft tissue injuries, sprains, which is ligament damage, and strains, muscle or tendon damage, the treatment is less dramatic. We use the acronym RCE.
R for rest the injured area. I for ice. Apply a cold pack, but always over a cloth covering to prevent ice burn.
C is for compress the area with a light bandage to reduce swelling.
And E is for elevate the limb above the heart level if you can to help drain fluid and reduce swelling.
Now, every bump to the head in a child must be treated with serious consideration.
Yes, all head injuries need a professional medical assessment, but you need to know the immediate signs of severity. We categorize them into 3 types.
First, concussion. This is a temporary disturbance of brain function.
Signs include a possible brief loss of consciousness, which can be delayed, dizziness, a persistent headache, maybe some memory loss or blurred vision.
Second, the more severe cerebral compression.
This is caused by swelling or blood pooling inside the skull, building up dangerous pressure. Signs here are an intense worsening headache, increasing drowsiness, pupils that are unequal in size.
A slow but strong pulse, and potentially noisy breathing. This is a real emergency.
It is. And third, a skull fracture itself. This might present with an obvious wound, a depression you can feel on the skull, bruising around the eyes or behind the ears.
Or, critically, the presence of cerebrospinal fluid, a clear, watery fluid leaking from the ears or nose.
And if you suspect a skull fracture, you must do not turn the head under any circumstance. The risk of an associated spinal injury is just too high.
Which brings us to spinal injury management. Damage here carries the highest risk: paralysis or death.
You have to prioritize keeping the spine stable. For a conscious casualty, your action is simple. Call 999 immediately.
Keep the child in the exact position they were found in.
And you must immediately immobilize their head and neck by holding it still with your hands. We call it manual inline stabilization. And you must avoid asking questions that make them nod or shake their head.
For an unconscious casualty with a suspected spinal injury, the rule is even stricter.
Only move them if their airway is at immediate life-threatening risk, like if they're choking on blood or vomit.
Otherwise, you keep them warm, monitor their ABCs, and ensure the head and spine stay perfectly in line until the ambulance crew arrives to take over.
Okay, let's talk about generalized seizures. These are caused by a sudden, excessive burst of electrical activity in the brain.
They're characterized by loss of consciousness, body rigidity, uncontrollable jerking of the limbs, the convulsions, and potential loss of bladder or bowel control.
Your treatment is purely focused on harm minimization and safety. You must ensure the child's safety by moving away any dangerous items, like furniture or sharp objects.
And gently cushion their head.
Crucially, you must not restrain them. You can't stop the seizure, and trying to hold them down risks injury to you or the child.
And the most important rule, absolutely never put anything in their mouth.
They cannot swallow their tongue. Trying to insert anything risks breaking their teeth, causing cuts, or actually obstructing their airway.
You have to time the seizure accurately. Once the jerking stops, you check the airway, clear any excess saliva, and place them into the recovery position.
Now, febrile convulsions are terrifying to watch, but are very common in infants and young children, usually between 6 months and 6 years old.
They are fits caused by a rapid spike in body temperature, usually above 38 degrees Celsius.
They look identical to a generalized seizure, loss of consciousness, stiffening, jerking limbs, a blue tinge to the lips, but they usually subside quite quickly.
Treatment is similar. Protect the head and time the convulsion. Because the cause is heat, you have to try and cool them down.
Remove excess clothing and blankets. Open a window for cool air. The core warning here is critical. Call 999 immediately if it's the infant's or child's first ever convulsion or if it lasts longer than 5 minutes.
Right. Diabetic emergencies fall into two distinct opposite categories.
Hypoglycemia, so blood sugar too low, and hyperglycemia, blood sugar too high.
Hypoglycemia has a rapid onset, sometimes just minutes. Recognition includes sudden blurred vision, intense hunger, confusion, or lethargy.
A rapid heart rate, tingling sensations, and feeling faint. The child may look pale and sweaty.
Treatment is immediate sugar. Sit them down, reassure them, give them fast-acting sugar.
Glucose tablets are ideal, but if you don't have them, use Jelly Babies. A sugary drink? A non-diet fizzy drink is perfect, or full sugar fruit juice. If their condition doesn't improve rapidly within about 10 minutes, call 999.
And hyperglycemia.
That's slower to develop, sometimes over hours or days. Recognition features include sweet, fruity-smelling breath, a bit like nail polish remover.
Increased thirst and urination, a dry mouth, and general tiredness or lethargy.
For hyperglycemia, you sit them down and encourage them to use their prescribed medication, which is often insulin. If they have been previously diagnosed with diabetes, or if they're drowsy, you must call 999.
Next up, asthma. This affects and narrows the airways.
Recognition includes breathlessness, a distinctive wheezing sound, especially on the exhale, chest tightness, long bouts of coughing,
and potential cyanosis, that gray or blue tinge to the lips and skin in severe attacks.
You assist them to sit down, leaning slightly forward, which is the best position for breathing. Assist them immediately with their reliever inhaler, usually the blue one, and make sure they follow their personal action plan.
And you must call 999 if the attack is prolonged, if their inhaler isn't working, or if it's their first ever attack.
Okay, we must discuss two of the most life-threatening childhood illnesses, meningitis and septicemia. This is a medical emergency.
Bacterial meningitis is particularly dangerous, especially for the under 5s. You have to get qualified medical help immediately if you suspect either.
The signs are varied and change by age. For infants, you're looking for a tense or bulging fontanelle, the soft spot.
An unusual high-pitched cry, a dislike of being handled, and possibly pale, blotchy skin or a rash.
For children, you're looking for the classic signs: a stiff neck, a severe headache, a dislike of bright lights, photophobia, severe muscle pain, and mental confusion or agitation.
And the definitive sign is often determined by the glass test.
Press a clear drinking glass firmly over any spots or rash. If the rash does not fade under the pressure of the glass, this indicates meningococcal septicemia. You must call 999 immediately.
But here is the major tip that Paul always stresses.
Don't wait for a rash to appear. It can be the very last sign, or it may never appear at all. If you suspect meningitis based on stiff neck, vomiting, and high fever, call 999 right away.
Finally, anaphylaxis, an extreme and potentially life-threatening allergic reaction.
The onset and progression are rapid. Recognition includes swelling of the mouth, tongue, face, and neck, leading to obvious difficulty breathing.
Often accompanied by red, blotchy, itchy skin, nausea, and intense anxiety.
Immediate treatment for a severe reaction. Identify and remove the trigger if you can. Call 999 immediately, and you must state clearly that the child is having an anaphylactic reaction.
If they are conscious, you lie them down flat and raise their legs, unless they are unconscious or having severe breathing difficulties.
In which case, you help them into a position that makes breathing easier.
Use their adrenaline auto-injector, AAI, if they have one, following the device instructions.
And if symptoms don't improve after 5 to 15 minutes, you can give a second injection if a second device is available.
Now for the final Paul's Practical Pearl in this section. Why is the hospital necessary after using an AAI, even if the child seems completely recovered?
It's because of the risk of a rebound reaction. The effect of the adrenaline is temporary. Once it wears off, typically 10 to 20 minutes later, the allergic symptoms can return suddenly and severely.
So monitoring by qualified medical staff is mandatory. Every single time.
Every single time.
Right. Section 5, Environmental and Burns Protocols. Infants and children are highly susceptible to both cold and heat injuries, aren't they?
They really are. They have a greater surface area to body mass ratio, which makes them less able to regulate their core body temperature.
So hypothermia occurs when the core temperature drops below 35 degrees C.
Recognition includes pale, cold skin, uncontrollable shivering, which then stops as the condition gets worse, lethargy, disorientation, and eventually a slow pulse and slow breathing.
Treatment. Remove them from the cold. Take off all damp clothes, replace with dry ones, and cover them warmly with blankets in a warm room, aiming for 24-25 degrees C.
You can give warm, sugary drinks, but crucially, do not warm them rapidly. Never use a direct source of heat like a hot water bottle.
Why not?
Rapid warming can cause vasodilation, blood rushing to the cold skin surface, which drops the core blood pressure and puts dangerous stress on the heart. Slow, steady warming is the key.
Moving to the opposite extreme. Heat exhaustion. This is when the core temp rises above 37 degrees C.
Signs include hot flushed skin, profuse sweating, headache, a rapid pulse, and dark, concentrated urine.
Treatment is simple rehydration and cooling. Move them to a cool, shaded place, remove excessive clothing, and give them water or a sports drink to rehydrate.
Then you have heat stroke, which is a life-threatening medical emergency. The body's thermostat, the hypothalamus, has basically failed.
And the core temperature spikes dangerously, potentially above 40 degrees C.
Recognition includes an extremely high core temperature, intense headache, lower response levels like confusion or collapse, and critically hot DRY skin because the body has shut down its sweating mechanism.
So that's the difference. Exhaustion is sweating, heat stroke is dry skin.
Exactly. Treatment requires immediate, rapid action. Move them to the coolest place possible and call 999 immediately. Give small sips of water if they're conscious.
And you have to initiate rapid cooling. Continuous sponging with cool water, applying cold packs to the neck, armpits, and groin, or spraying them with water.
And here's a crucial Paul's Practical Pearl for prevention that applies to every single person listening.
Keep children out of the hottest sun between 11 a.m. and 3 p.m., provide plenty of cold drinks, and absolutely never, under any circumstances, leave a child in a parked car.
The internal temperature of a vehicle can become lethal in minutes.
Let's talk about electric shock. For high-voltage sources, like industrial cables or overhead power lines, you must not approach within 18 meters.
You have to keep everyone away and contact 999 and the electricity supply provider. Only approach when the scene is officially declared safe.
For low-voltage injuries from a domestic supply, you have to isolate the power source immediately.
Switch the circuit breaker OFF, pull the plug if it's safe, or if you have to, move the child away using a non-conductive object like a wooden chair or a broom.
Once the power is isolated, check their response levels. If unresponsive, you perform BLS and call 999.
Remember, electricity can cause internal damage, disrupting the heart's rhythm, even if the external burn is minor.
Burns and scalds are tragically common. The management protocol is universal for all types.
Initial action is cooling. Remove the source of the burn, put on your gloves. Remove any restrictive clothing or jewelry unless it is stuck firmly to the skin.
Do not try to peel off clothing that's stuck to the burn.
The single most effective treatment you can provide is cooling. You must flush the burn area with cool running water for a minimum of 20 minutes.
Set a timer. Cold water reduces the pain, but more importantly, it limits the tissue damage that continues under the skin's surface.
For dressing, use a loose, sterile dressing. Or, even better, place a layer of cling film over the burn.
Now, Paul's Practical Pearl on cling film is great.
It is fantastic because it's easily available, it protects the burn from airborne infection, and it doesn't stick to the damaged tissue. Plus, medical staff can see the burn through it.
Remember to peel off and discard the first few inches of the roll to make sure the layer you use is sterile.
And you must seek medical attention immediately if the burn covers more than 5% of the body, the child's entire hand is roughly 1%, or if the burn affects the airway, face, hands, feet, or genitals. And don't burst any blisters.
Finally, a chemical burn to the eye.
You have to act immediately and forcefully. You must wash the eye with fresh running water for a minimum of 20 minutes.
And while you're irrigating, be really careful to make sure the chemical doesn't run into the other unaffected eye.
Then you cover the affected eye with a sterile pad and seek medical attention straight away.
Right. That was an incredibly detailed walkthrough of the PFA manual. But before we transition to the hands-on practice, let's drill those life-saving procedures with a quick fire round. Are you ready?
Ready. Let's lock this information down.
Scenario 1. A 2-year-old in the nursery is eating lunch, suddenly grasps their throat. They can't cough or make a sound. What's the first physical intervention?
Severe obstruction. Lean them forward, support the chest, and administer up to 5 sharp back blows between the shoulder blades.
Scenario 2. You've checked a child. They are unresponsive and not breathing normally. You've called 999 on your mobile, put it on speaker. What's the very first thing you do before compressions?
Pediatrics. Oxygen is paramount. Give 5 initial rescue breaths to try and fill those lungs.
Scenario 3. A Year 4 student has just spilled a cup of very hot tea on their forearm. They are screaming. You are flushing it under the tap. How long minimum?
20 minutes. The full 20 minutes to stop the tissue damage from progressing.
Scenario 4. A toddler is having a febrile convulsion, eyes rolling, body jerking. Do we put a spoon or anything in their mouth?
Absolutely not. Never put anything in the mouth. Clear the area, protect their head, and accurately time the seizure. Call 999 if it's their first time or it lasts over 5 minutes.
Final scenario. You've used an AAI for a severe allergic reaction. The child seems much, much better. Breathing is normal. Do they still need to go to hospital?
Yes, every single time. Without exception, call 999. They need mandatory monitoring for that rebound reaction when the adrenaline wears off.
Perfect. That quickfire round should have cemented the immediate priorities. You've mastered the theory, you know the signs, the protocols.
This deep dive was the roadmap, but now you need to build the muscle memory. You're now transitioning to the hands-on stations with Paul Kenny and his team.
Our final piece of advice. Be an active participant. Don't just watch. Get hands-on. Feel the difference between an infant's chest and a child's chest.
Paul will guide you through 4 absolutely vital practical skills today. First, CPR on the mannequins, covering those subtle but essential technique differences.
Second, choking management, comparing the sharp infant chest thrusts against the child abdominal thrusts. You need to feel the pressure.
Third, wound management and bandaging, focusing on correct direct pressure and mastering the technique for embedded objects by dressing around them.
And fourth, mastering the recovery position, practicing how to safely turn both an unconscious infant and an older child, making sure that airway is maintained.
The confidence you gain in the next few hours is invaluable. It's the difference between panic and procedure. It's what saves lives.
That's it from us on the deep dive into the Pediatric First Aid Manual. Good luck with the hands-on session, everyone. Thank you so much for your dedication to the safety of the children in your care.
A huge thank you once again to Paul Kenny and the entire First Aid Garage team for their decades of dedication to child safety across the UK. Now go practice and stay safe out there.